Good morning, and welcome to Meds Ed, the ongoing clinician series brought to you by CareOregon Pharmacy. I'm Paul Carson, and today's topic is innovations in pediatric health complexities and social risk. Here's the agenda for our program this morning. We'll begin this morning with Dr. R.J. Gillespie. After that, we'll be introducing Dr. Kimberly Spiro, and then we'll move into Dr. Keith Cheng. And after Dr. Cheng's segment, we'll move directly into the live panel Q&A segment. We will be focusing on improving your ability to manage children with social complexity and behavioral health needs, your ability to manage children with medical complexity, including care coordination and DME medications, and your ability to use data to consider risk to help design meaningful interventions for children, including special populations and age group. Our first presentation this morning is from Dr. R.J. Gillespie, a general pediatrician with the Children's Clinic in Portland. From 2007 through 2010, he worked as the medical director of quality improvement for the Children's Health Alliance and was also the founding medical director for the Oregon Pediatric Improvement Partnership. He currently conducts clinical research in parental adverse childhood experiences and does training and consultation in screening and referral for trauma in pediatric practices throughout the Oregon Pediatric Society. He's been active in multiple states and national advisory committees, most recently for the American Academy of Pediatrics addressing social health and early childhood wellness, and the Pediatric Approach to Trauma Training and Resilience Projects. He attended medical school at Oregon Health Science University, graduating in 1997, and completed his residency and chief residency at Rush Children's Hospital in Chicago. He also earned a Master of Health Professions Education from University of Chicago in 2007. Please join me in giving your attention to Dr. R.J. Gillespie.
Good morning. My name is R.J. Gillespie. I'm a pediatrician with the Children's Clinic, and this morning I'm going to be talking to you about our clinic's integrated response to parental ACEs. But before I get started with the work that we've been doing clinically, I wanted to do a little bit of level setting, just to give you a little context about how we got to where we are with our project work. My quality improvement work and clinical research relate to early childhood health, and I have a particular interest in kindergarten readiness. When thinking about management of complex patients in early childhood, though, medical complexity is relatively uncommon. However, risk is very common if you know how to look for it. A lot of developmental and social emotional risk actually comes from the child's environment. The trajectory of my work started in 2008 with work that I did with the Oregon Pediatric Society and Children's Health Alliance, specifically around screening for developmental disabilities in primary care. After that, through a project with the Oregon Pediatric Improvement Partnership called the ABCD3 project, we learned about the enormous gap between identification of kids at risk for developmental disabilities and connection to services. We found specifically that 40 to 50% of kids who were referred to early intervention by their primary care provider never actually connect with services. And this was illustrated to me by a very specific patient that I remember very clearly from about 10 years ago. He was a 6-month-old who came in for just routine well care. And what was remarkable about the interaction was really how mom was responding to both me and to the child. So she put her baby down on the exam table, shoved him all the way up against the mirror, and then went over and sat down. And when I asked her, well, do you have any questions for today? She said, no, should I? And through the course of the visit, it came clear that she was actually struggling with pretty severe maternal depression. I offered her services. She declined, did my exam of the baby, and what was particularly memorable was that he was a very smiley, happy baby. He was doing all of the tricks that infants do to try to engage me to get attention back. So he was just hungry for some back and forth attention. The next visit at 9 months, when we did our developmental screen, he failed it. Again, I referred mom to services, which she declined. And over the next 18 months, I saw this baby go from a happy, smiling, engaging child to a screaming, spinning in the corner, not responsive to anyone toddler. And so what I was seeing was the progression of autism basically happening in my office in front of me. And in retrospect, I know that a lot of that had to do with the child's environment, as I said, and particularly that mom was struggling with depression and was not able to really bond with her child in a way that was normal. And so for me, the lesson in that was that screening for developmental disabilities by itself wasn't sufficient for helping children. And really, we had to take a look at what puts kids at risk for developmental delays specifically, but also what puts a child at risk for not being able to connect with services that are necessary to address those particular risks. And that really comes down to having a better understanding of the social and family context that either helps kids to thrive or doesn't. Within the next couple of years, I was recruited to a project with the American Academy of Pediatrics called the Medical Home for Kids Exposed to Violence, which is when I first learned about the Adverse Childhood Experience Study. This study was published in 1998 and really was a groundbreaking study in that it connected early childhood traumas with later life health risks. And in the words of the author, Vince Felitti, we found a strong and graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several of the leading causes of death in adults. In the specific adverse childhood experiences that Dr. Felitti and his colleagues looked at were categories of abuse, physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunctions that were characterized by living with a family member with mental illness or substance abuse problems, having a relative that was incarcerated, witnessing domestic violence, and then divorce, separation, or loss of a parent. What he found is that multiple exposures to ACEs resulted in much higher risks of most of the things that we worry about from a medical and a public health perspective. So if you look at this long list of diseases and disabilities, these can all be at least in part attributed to adverse childhood experiences. The way I was trained medically, these are diseases in and of themselves, but when you read the ACE study, it becomes clear that these things are actually symptoms of unresolved and unaddressed trauma. We know now that there is a lot of different body systems that are affected by recurrent or persistent exposure to trauma, including alterations in how the brain develops, changes in how genes are expressed, which is referred to as epigenetics. So the epigenome is a layer of proteins that lay on top of the DNA and decide how the DNA itself is expressed, either by turning genes on or turning them off. And we know that trauma has a clear effect on how genes are expressed through the epigenome. Results in endocrine and immune imbalances, decreased executive function and ability to regulate your emotions. It creates a difficulty in relating to other people, so an interference in relational health. Behavioral allostasis, and then ultimately leading to chronic illness, health disparities, and a decreased quality and length of life. I want to highlight in particular the interference with relational health because that forms the foundation for what we do looking at parent ACEs. In 2012, the American Academy of Pediatrics published a policy statement around toxic stress saying that pediatric medical homes should do a number of things. First, we're supposed to do a better job in providing anticipatory guidance that supports kids' developmental skills, so their social, emotional, linguistic skills, but also to help encourage the adoption of positive parenting techniques. We are directed as well to actively screen for the precipitants of toxic stress that are common in our particular practices, to develop, help secure funding, and participate in innovative service delivery adaptations that help medical homes to support kids at risk, but also to identify or advocate for the development of local resources that address the risks for toxic stress that are prevalent in our communities. And this was really a tall order. So the things that were missing from the policy statement were really how that was actually supposed to be done. We weren't given a roadmap that would tell us when do we screen, what tools do we use, how often are we supposed to be screening, and most importantly, what do we do if we actually find toxic stress in our practices? As pediatricians, we were interested in getting as far upstream as we could, meaning that rather than waiting for adverse childhood experiences to happen to our kids, we were interested in figuring out how to try to prevent them at all. That led us to looking at parent trauma, and there are a couple of lines of research that support why trauma in parents is actually important for the development of children. The first, and this comes from Denise Dowd's group in Kansas City, is that there are correlations that are seen between the parent's adverse childhood experience, or ACE score, and the child's eventual ACE score. So that the more ACEs a parent experiences, the more ACEs the child is likely to experience throughout their lifetime. That's not to say that there's a linear correlation between the types of adversities that parents experience and children experience. So it didn't imply that, for example, a parent who was physically abused would go on to physically abuse their child as well. However, a parent who had been physically abused might have higher risks of depression, substance abuse, problems with their own relationships, and then those become the ACEs for the next generation. That said, within the psychology literature, it has been shown that parenting styles are at least in part inherited, so that a parent who experiences harsh parenting styles themselves are more likely to engage in those styles with their own children. And the thought there is that what we know about parenting comes from how our parents treated us, because they are our greatest role model for how to be parents for our own children. So if that was a negative experience, then parents may not have other ideas to draw on in terms of how to parent their own children. The third, and this relates to research in neuroplasticity that's being done at the University of Denver. When I was in medical school, I was taught that by the age of 3, all of the gray matter that you're ever going to have in your brain has already been developed, but that has been found over the last several decades not to be true. And that new parents, in fact, have brain growth in the first 6 months after their child's birth. This is both mothers and fathers. Mothers a little bit more than fathers, but they have brain growth in 2 critical areas: the amygdala, which is essentially your emotional center, and the frontal cortex, which is your logical center that allows you to control your emotional center. And both those areas of the brain will grow unless the parent is under extreme stress. In those circumstances, the parents would have growth in the amygdala, or the emotional center, but not in the frontal cortex, which leads parents with an emotionally reactive brain that they don't have the frontal cortex physiology to be able to regulate. And the last piece talks about kids who have experienced 3 or more ACEs before entering kindergarten. And this research has shown that if kids have 3 or more ACEs, that they have worse kindergarten readiness scores by the time they enter kindergarten. So not only are their literacy, language, and math skills lower, but also they have higher rates of behavioral problems. And I always pause at that to remind people that when we're talking about 3 or more ACEs before entering kindergarten, that's saying that these ACEs are happening to children when they're very young. And in fact, the research would suggest that if a person has a high ACE score, that they usually have picked up several of those ACEs before the age of 3. And the majority of them are picked up before the age of 6. So if we're trying to prevent ACEs from happening, we really have to start at the very beginning. So what we did as a clinic, we started with the assumption that if we were able to identify parents who are at greatest risk, bring their trauma histories out of the closet, and agree to support them when they feel most challenged in a non-judgmental way, that perhaps we would be able to create a new cycle of healthier parenting. And when we started, that was really all we were trying to do. I don't personally have kids, but I'm told that it's stressful. There are certain times within a child's life that are going to be more stressful for parents. So some of these examples would be when toddlers naturally have tantrums, if they happen to have colic, the stresses that come around toilet training, the natural toddler hitting and biting that happens to almost every family, and then problems with sleep would be examples of when parents might be particularly taxed by their child's behavior. If a parent has experienced trauma, what we worry about is that potentially that would trigger their fight, flight, or freeze response. And if parents are aware of their own history and how that might impact their parenting, would we be able to prepare those parents for a reaction that is outside of that fight, flight, or freeze response? In other words, can we better prepare at-risk parents for those inevitable moments in their child's life? And then thinking further, if a parent has experienced trauma, they may not have the skills or ideas for how to take care of themselves, how to identify when they need help, either from their provider, from their support network, or from other people, how to model appropriate conflict resolution, how to do discipline that is really reflective of where the child is in their development, and even how do parents play with their children, and do they have ideas about how to play with their children? In fact, I worked on a panel once with a father who had experienced a pretty traumatic childhood, and that was his biggest concern, was every time his child came up to him and said, "Daddy, play with me," he didn't know what that looked like because no one had played with him as a child. So in other words, can we teach parents and children how to be more resilient? Within our practice, just to give a little bit more context, we have 30 providers between 3 practice sites, and they have always shared my interest in early childhood development and in developmental promotion. And since 2008, we've developed multiple universal screening protocols, starting with developmental delay and autism back in 2008, followed in 2009 with maternal depression screening. And since then, we've also done standardized screening for adolescent depression and adolescent substance abuse. All that to say that we've done a lot of different screening protocols. And so the workflow around standard universal screening is fairly easy for us to plug in. We had never really addressed trauma specifically in a universal way. Our adolescent questionnaire had some questions around dating violence and around bullying to some degree, but it wasn't a comprehensive or universal look at trauma within our practice. So when we started looking at parent ACEs, our initial steps were to start with just a few providers who would pilot the screening and see how it went. We started at the 4-month visit, giving parents both the ACE screener along with a questionnaire about resilience and a list of potential resources where parents would be able to select what resources they thought would be helpful for them. Those resources included things like parenting classes or support groups, home visiting nurses, respite nurseries, or if they just wanted more information about trauma and resilience. We also wrote a cover letter that explained the rationale for the screening tool and what we plan to do with the information. Within our electronic medical record, we created a confidential field so that we could document the results, but those results wouldn't print into any notes. That was done in order to ensure some privacy to the families, that their ACE score, if they choose to share it with us, would not be spread to specialists, or if they left the clinic for whatever reason, it wouldn't be revealed to their new provider, for example. We thought this would minimize risk to families while helping us to still see the results. After our first pilot, we decided that we wanted to add questions around community violence, bullying, racism and prejudice, and foster care exposure to expand what we were looking at in terms of adverse childhood experiences and how those were defined. Our initial goals were just to see how do we best assess parent ACEs in primary care. In other words, was it something that was feasible to do in the course of a primary care visit? A lot of people were concerned that we wouldn't have time to get through this kind of an assessment, that we wouldn't clinically know how to respond to the families. We wouldn't know how to emotionally navigate the conversations, which sometimes were very challenging conversations. And so the initial pilot was really to say, are those things feasible and doable within primary care, or would we in fact be so bogged down with the way parents responded that we couldn't navigate the rest of our visits? And I will say, in summary, I have many, many slides that talk about how our providers reacted, but it was not at all what we expected. All of the providers universally felt that this was helpful information for our clinical visits. We rarely had to do anything different in terms of our immediate plan. And all of the providers, when we eventually spread this to the entire clinic, said that they would never stop doing this screening, even if I were to leave the practice and not be pushing them to do it, that they found this information far too valuable. Parents also responded extraordinarily well to this screening. I think that most of the time when you have a trauma history and then you have a new child in the house, it is a fear in the back of every parent's head that they're going to repeat some of those mistakes. And so to have that basically just drawn out into the open, where it's a safe place to talk about those particular fears, really led most parents to feel very positive about the screening experience. But after we did our initial feasibility work, we started looking at risk for suspected developmental delay. And what we found is that the more parent ACEs a parent had experienced, the more likely the child was to fail their developmental screen at age 2. And as you can see on the left column, we looked at the maternal ACEs and found that with 1 or more ACEs, 2 or more ACEs, or 3 or more ACEs, there's a gradual increase in risk of failing the developmental screen. Father's ACEs were a little bit stronger in terms of predicting risk, although once you got to 3 or more ACEs, we didn't have enough dads in that group to really extrapolate out the data past 3. But you can see that those numbers were in fact higher if dads had ACEs. And the combination of prematurity and ACEs was particularly powerful on the dad's side. So looking at the bottom row of the gestational age of birth over the age of 37 weeks, that's anchored to whether parents had 2 or more ACEs or less than 2 ACEs. And if it was the mom that had 2 or more ACEs and the kid was born prematurely, there was about a 1.7 times risk of failing the developmental screen at 2, which was not statistically significant. But when you look at dads having 2 or more ACEs and kids being born prematurely, 7.76 times more likely to fail the developmental screen, which was very statistically significant. When I first presented this data to some colleagues to try to help me make sense of it, the initial response was toxic masculinity, which, maybe that's true, maybe it's not, but probably more likely, another colleague had talked to me about support groups or support networks for parents if they had a kid with special health needs. And if you ask moms of a child with special health needs, who's in your support network, they'll be able to identify 3 to 5 people pretty easily. If you ask a dad who's in your support network, usually 0 to 1 people that they can identify. And usually the 1 is mom. So what we're looking at is if dads experienced ACEs, then they probably don't have the social network and the social connection to help buffer the effects of those ACEs and how that might help or hinder them from relating to their child. So all that to say that overall, we see that parent ACEs affect development. Dad's ACEs, again, a little bit stronger than mom's ACEs. When we looked at the specific domains of developmental risk by maternal ACE exposure, which again, we had more moms to work with in terms of the study, we found that with a single maternal ACE, kids were more likely to fail the problem-solving domain. So it only took 1 ACE to disrupt that part. 2 or more ACEs, the kids were more likely to fail 3 out of the 5 domains. So they were also more likely to fail communication and gross motor. And then with 3 or more ACEs, they were more likely to fail all 5 domains of the developmental screen. When we estimate or extrapolate out the data, our best guess is that if a mom has 10 or more ACEs, then there's about a 75% chance that that child will eventually fail their developmental screen. So this is how we estimate out that risk. Now, our data is not the only data that looks at the relationship between parent ACEs and children's outcomes. There was a study that looked specifically at behavioral outcomes in kids and found that the more ACEs that a parent has, the more likely that children are to have behavioral problems. For example, there was a higher score on the behavioral problems index. There were higher odds of hyperactivity and higher odds of emotional disturbances like anxiety and depression. And in that study, it was a higher correlation for maternal ACEs than paternal ACEs, so the opposite of the relationship that we found. There have also been studies into parent ACEs and overall health outcomes, so finding that for each additional parent ACE, for example, there's a higher adjusted odds ratio of overall health status being poor, higher rates of asthma, and higher rates of poor parenting practices like excessive media use. And since these effects are cumulative, if a parent has 6 or more ACEs, then their child was over 6 times more likely to have asthma. So even some medical problems are related specifically to parent ACEs. We more recently have looked at utilization patterns and found that for each additional maternal ACE, there is about a 12% increased risk of children missing their well visits in the first 2 years. And while this didn't result in missing immunizations, we do think that this means that kids are more likely to miss their developmental screens, more likely to not be receiving anticipatory guidance on developmental promotion, and possibly getting delays in referrals to services. So all that to say, when you look back at the literature in terms of why parent trauma matters, we know now too that there's a strong correlation between parent ACEs and their child's developmental, behavioral, and overall health risks. So now what? And this is really where we started looking at how we transform our own well care to address these particular risks and hopefully eventually get to some prevention. The first thing is that we have to look at screening tools a little bit differently. When we started training providers on how to do these different screening protocols, most of those assessment tools became just one more thing for providers to do. But I think when you look at the data around the outcomes for parent ACEs, you really have to look at how those screening tools relate to each other and how they together can change how we do workflows for children. For example, if you look at the current state in terms of in terms of screening tools and the recommendations of when we're supposed to do them, we're supposed to do maternal depression screens at every visit in the first 6 months. We're supposed to do developmental delay screening at 9, 18, and 30 months, autism screening at 18 and 24 months. We're supposed to do social emotional developmental screening at semi-undefined intervals. And then if you add in social determinants of health or other screening tools, what that becomes is really, did they pass, fail, do we refer or observe, or do we move on? And each of those independent screening tools becomes its own to-do item. But I think if you look at developmental health as the overall goal for early childhood, then you start looking at how these different screening tools relate to developmental health. And you can imagine that if you have a child who has failed a developmental screen and there's the presence of maternal depression, that gives you a different workflow and a different response than if there are, for example, social determinants of health that might be causing a child's developmental health problems, or if there are parental ACEs that may be affecting a child's development. In the absence of all of those things, perhaps a referral to physical therapy, for example, might be appropriate. But if one of those things is present, then you do different referrals than you would if there was none of these present. All of these then relate to a child's overall social emotional health and whether or not they're ready for kindergarten. So again, looking at screening as a more integrated process rather than individual checkpoints in a child's life helps you to change how you look at overall clinical care. When talking about ACEs in particular, this concept comes from Andy Gardner, who wrote the book Thinking Developmentally, which really was meant to help primary care providers start thinking about how we look at trauma and how we address trauma within practice. And his idea really is to take a public health approach to trauma as well. And so everybody, regardless of whether there's the presence of trauma or not, will get some universal precautions and preventions. So we give some consistent messaging about the effects of trauma. We do some positive parenting interventions. And then for those who have toxic stress exposures, either because of child ACEs or parent ACEs or some other social determinants, then we give targeted interventions to those families. And if there are actually symptoms because of those exposures, then that's another third level of response, where those children would be referred into specific therapies like parent-child interactive therapy or trauma-focused cognitive behavioral therapy, so that when you think about trauma, everyone gets some degree of basic information about trauma, and then you assess risk in some way, and then find those kids who need to go on to specialized services. And so for us, the ACE assessment tools become an opportunity to provide that universal education about trauma and resilience. So that's that level one. Everybody gets some education about trauma because of the tools that we're using. Then we use our tools to identify families that may be at risk, and then therefore get some extra help in positive parenting, relational and attachment repair or other interventions. And then for those parents that still have trauma symptoms or families that are experiencing trauma symptoms, then we can move them on to evidence-based treatments. And so in that sense, our assessments are meant to touch all three of those different layers of a public health response to trauma within practice. So here's what we're doing. I think the first thing to remember as a primary care provider is that it is not our role to fix everything. It is not our role to address all the different aspects of trauma within practice. And really, we need to look at how we do this as a team within our practices. And looking at motivational interviewing concepts, There's the idea of the righting reflex, which is that we as providers are trained that whatever problem we see in our office, it is our job to fix that. That is the righting reflex, the idea of righting the ship. With conversations about ACEs and trauma, I think that success really is relational rather than looking at a specific outcome. The first thing to remember is that if you screen for ACEs, the goal is not about forcing a disclosure. And I think that's a concern that people have when we talk about screening for ACEs is that the goal is to find out yes or no, was there trauma? But I think that in these cases, success really is about, is the door open to further conversation? So whether a parent or a patient is comfortable disclosing trauma to you, you want to leave the visit with the parent or patient feeling that if they do want to disclose to you at some point, or if they have some other issue that they need to disclose to you at some point, that this is a safe place to do it. The way that's played out for me in practice is since we started screening, and we've been doing this since 2013, I've had 15 moms who have spontaneously revealed domestic violence to me at some subsequent visit after talking about ACEs within practice. I've also had other parents who have disclosed food insecurity to me, problems with their relationships, recent losses in their family, and oftentimes when we go into a visit, we'll have the experience where there's something else underlying a parent's concerns or questions that we don't quite know what it is. And creating a culture of safety by allowing people to disclose within practice if they choose really has helped parents to bring those sorts of social concerns forward without having to feel judged or embarrassed by it. And that to me is, again, how success in conversations around ACEs really goes. In order to do that, the conversation should be validating, safe, and non-threatening. And again, if we're leaning on our training to fix everything, then we're not being present to listen to the story. And I think that's the biggest factor in creating a culture of safety for families. And I think ultimately parents' behaviors make a lot more sense if you understand their story. One of the classic lines within trauma-informed care is, instead of thinking what's wrong with this person, think what's happened to this person. And it helps you to understand their behaviors a lot better. If you add on, how can I help? Then that's where we come in as clinicians. So not just what happened to this person, but also how can I help? And in terms of creating a culture of safety and a space to heal, this is data from the National Survey of Children's Health, which said that positive relationships with providers matter for building resilience. And so, for example, children with 2 or more ACEs whose parents report that their child's healthcare provider always listens, spends needed time, and gives needed information are 1.5 times more likely to live in families that provide basic resilience skills or practice basic resilience skills. And children whose parents always report having positive communication with their child's healthcare providers are over 1.5 times more likely to practice recommended protective family routines and habits, like having a bedtime routine and reading regularly. This is really to illustrate the power of listening. So this is not a fancy intervention from a clinical perspective. This is about listening and being present and available for your families. So if we, as providers, are able to listen and spend needed time, then our parents are more likely to practice the things that we are recommending that they do. The way that I initiate the conversation to help parents and patients is to start by thanking them for opening up about their experiences. I think that this helps to validate the importance of the conversation and also helps to communicate the message that these are often difficult things to talk about, and that you appreciate that the family is willing to be vulnerable with you and to have that conversation openly with you. Then I ask these 3 questions that help me to navigate what I need to do next. So the first, are there any of these experiences that still bother you now? And that question gets at immediate safety for the family. So if there's some experience from the past that is still bothering that family, then that's where we start getting into looking at trauma symptoms and whether or not they need to be referred on to specialty services. The second question, of those that no longer bother you, how did you get to the point that they don't bother you? This gets at resilience. So what is the factor that helped the family or patient to get over that particular trauma? Then you can assess if that resilience factor is still present. So if it was a relative, a loved relative that helped them get through the experiences, is that someone who is still in that person's support network? If it was their own grit and determination or some personality trait that helped them, is that something that they feel that they can still draw on? And then finally, how do you think these experiences affect you now? Helps parents to start drawing the connection between their experiences and how they respond to their child in terms of their parenting practices. One of the things that we've implemented in our practice to start transforming how we're doing care is universal resilience interventions. So at every one of the well visits in the first year, we've had all of our providers trained in specific interventions that relate to the child's developmental age. So these relate to parent self-care, promoting attachment and attunement, and building resilience in parents. We're working on building a data collection to measure outcomes for kids based on which interventions were delivered and how many of those interventions were delivered. But here's some examples. So assuming that parent ACEs, again, affect development by disrupting attachment and attunement relationships, what we want to know is if we teach parents about resilience at each well visit, would we be able to make a difference? So at the newborn visit, we assess the circle of support. So who are the people that the parents can call any time of the day to get help? Who's in their secondary support and who's in their sort of system support, so that we have an intervention for looking at how parents feel supported as they're starting to raise their children. At 2 weeks, we start talking to them about parent self-care. At 2 months, we talk about mirror work. And then a focus on attachment at 4 months. 6 months, the special time intervention is the main topic. 9 months, we review some of those earlier topics. And then 12 months, we start talking about discipline. And these different interventions are all ones that can be talked about in 2 or 3 minutes, so they're fairly quick. But that means that every parent is getting at least a little bit of information about resilience from us. From there, we wanted though to expand our assessment of kids at risk. So right now, the American Academy of Pediatrics guidelines for maternal depression recommend that we do social emotional screening for kids whose parents experience depression. And the idea there, thinking back to that patient that I talked about at the very beginning, is that if a parent experiences depression, then there's probably a disruption in the attachment and attunement relationship. We believe that there would be the same theoretical disruption with parent ACEs and the attachment attunement relationship. So it made sense to us to create an analogous workflow for positive ACE screens. A couple of years ago, we added integrated behavioral health consultants into our practice. And so they are now being worked into our workflow to take over some of the social emotional assessments and the interventions that we do with those families. So the way it works, we break down whether the parent ACE score is 0, 1 to 3, or 4 or higher, or if it's 1 to 3 with some symptoms or safety concerns. And so every family is getting the resilience interventions regardless of their ACE scores. So they're getting that universal education about trauma and resilience. If there is an ACE score, anything 1 or higher, then we do the safety assessment doing those 3 questions that I mentioned, and then also assess whether there are any resource needs that the family identifies. From there, we can refer either to our care coordinator or to Help Me Grow as needed, depending if they are resources that we can provide within the practice or if they're resources that we need to go to the community for. And for those families where the parent ACE score is 4 or higher, or 1 to 3 with symptoms or safety concerns, then what we're doing is scheduling a joint 6-month visit with our behavioral health consultant, where the BHC would do social emotional development screening, do a video interaction intervention, and then if there are concerns based on that visit, schedule another visit jointly at the 9-month visit, so that at those well visits, the families are seeing both us and the BHC. And if there's still concerns at 9 months, then we would refer out to parent-child interactive therapy or another evidence-based therapy. So with that, we started the Embrace cohort, which was short for Emotional Behavioral Risk and ACEs, and we rolled that out in February 2020. So COVID happened after that, and so that sort of tanked a little bit in terms of what our plans are. But the way that would look is, rather than looking at just our parent ACEs, we would be looking also at those families that experience depression or families with some social determinant indicators like food or diaper insecurity, which we're starting to screen for at the 2-week visit. And then those families would get that same workflow where we start with a co-visit with our behavioral health consultant, to do that social emotional screening, the video interaction, and brief parenting intervention. And if that's all normal and all goes well, then we would continue our routine developmental screening and surveillance. If there's some abnormality, then we do the second co-visit. So rather than, again, offering this particular integrated response just to the parent ACEs, we know that there are other pathways that would lead these families to needing this additional service. So what's left for us to do as a clinic? We need some better tracking mechanisms within our electronic health record. It is very difficult, as most people know, working within an EHR to do any sort of registry functions. And so we're trying to figure out if we do dummy codes for tracking, or if we have pop-up alerts or some banner notations that help us to identify who those families are that are getting the additional services from us. We are, as I mentioned, working on studying the effects of the resilience interventions and our behavioral health consultant interventions, with the hope that eventually we would be able to prevent some of those developmental outcomes that we found in our early research. And so we really want to try to also help understand how our parent resilience, meaning the resilience score that we get on our initial assessment, how that helps to refine our assessments of risk within the population. So for example, if you look at parent ACEs by themselves, you might have one pathway for how you assess risk, but there's going to be a big difference between a parent who has a high ACE score and also has a high resilience score compared to a parent who has a high ACE score and has a low resilience, that may confer a different level of risk. Conversely, parents who have no ACEs but low resilience may also have some risk as well. And so that's something that we're working on trying to parse out, to get a little bit better idea of how we predict which families need the support from us more consistently. So with that, a couple of final thoughts. We're hoping that our early identification of risk within our patients and families can allow some prevention of the medical and behavioral complexity that we see in kids later on. As I mentioned, screening by itself doesn't get kids and families what they need. And so we really need to be integrating what we find on the screening tool with what we know about the family context. And finally, that an appropriate response to an identified risk takes a team approach. It's not something that a provider can do in isolation, but really we need to have all hands on deck for helping these families and providing the services that they need. And with that, we'll turn over to the next presenter. Thank you.